So thank you very much. We're going to talk about a little bit about our IV smart pump usability and safety initiative, as well as we have lots of folks that are also engaged in the space that are going to share their insights. I'm going to start with introductions. So first we have Juuso Leinonen, and he's a principal engineer at ECRI's Device Evaluation Group. Juuso is the lead engineer on infusion pump technology and has tested and evaluated most infusion pump models marketed in the U.S. He has over 8 years of experience in healthcare technology field and has been the lead investigator on a number of infusion pump accident investigations, some of which have resulted in global infusion pump recalls, a few of which we'll talk about today. And then we have my wonderful UMass colleague, Dr. Juan Jimenez. He's an assistant professor in the Department of Mechanical and Industrial Engineering right here. His research focuses on experimental cardiovascular biomedicine and medical devices, and he combines fluid dynamics and vascular biology principles to optimize stents deployed in atherosclerotic lesions over aneurysm necks. And most recently, his lab has become more involved in flow rate accuracy studies with the IV infusion pump. So thank you. And then a recent colleague, Cidalia Vital. She's a nurse leader for over the past 14 years, and in her current role, she is the Program Director of Nursing Research and Holistic Nursing at Baystate Medical Center in Springfield, Mass. And Cidalia and I will be working together as nurse scientists, so I'm really excited about that. Prior to joining Baystate for the second time, she was there once before, Cidalia was the Chief Nursing Officer at Encompass Health of Western Mass. Cidalia has been a longtime Baystate leader in roles as Magnet Program Director, Assistant Manager, and Nurse Educator. And she's passionate about involving bedside nurses in evidence-based practice, quality improvement, and research. And she's co-chair of the Association of Rehabilitation Nurses National Research Committee, and has presented both nationally and internationally about the importance of including the voice of the bedside in decision-making and evidence-based practice. So please join me in welcoming our panelists for this last. So what I'm going to do is I'm going to start with a brief overview of this, and this could be days because this is a pretty complex issue, but I'll start with trying to paint at least a little bit of the global picture, and then I'll hand it off to my colleagues to share their perspectives. So IV smart pumps, as I think I mentioned probably this morning, this is Nat Sims. So he's a inventor of the drug library and the dose error reduction system, which really led to the most quantum leap that we had in improving safety with infusion devices over the past, probably 20, 25 years. So it really made a huge difference. And as I mentioned this morning, he is a constant mentor, contributor, and collaborator with our group, and it's just wonderful to have him in our corner. Unfortunately, as with even the greatest leaps in safety, there's still errors that happen, and even though the drug library improved some things, it actually also induced other things that didn't happen before, and some of that is what we're trying to study and improve today. Just a little bit more of the background is it's one of the highest risk interventions, if you really think about it, in U.S. acute care. And just to be fair and let you know, our program of research here so far is focused solely on the large volume infusion pumps, though the ones you see in acute care in the U.S. market. We haven't gone into ambulatory pumps or syringe pumps or anything yet, although it's certainly within our scope of interest in the future. But 90% of hospitalized patients receive an IV infusion during their stay. So not only are these pumps used everywhere, and they're used to deliver the most highest risk medications, but they're used in almost every patient. So they're a big deal, and they're probably the most ubiquitous piece of medical equipment, I would say, at least in acute care. The smart pumps have over an 80%, according to the latest ISMP, Institute for Safe Medication Practices survey, over an 80%, probably more over a 90% adoption rate. So they're widely used throughout all of U.S. acute care. And unfortunately, they're also among the most frequent sources of error reported to the FDA, and serious error. Also an unfortunate thing is the most common IV smart pumps that we use in acute care are decades old. More like 30 years old, the linear peristaltic pump technology. The problem with IV pumps, if you think about it from a deployment perspective, if you want to get a new x-ray machine, because you don't like your old one, you can try one, wheel it around, test it, it works or it doesn't work, and then you can buy some more, and eventually you've turned over your whole fleet. With pumps, you can't do that. You have to you have to do an entire forklift upgrade. So you're really taking a chance, and the barrier to entry, therefore, because it's millions and millions of dollars in both product and training, to switch over your pump. You can't do incremental changes. So that makes the barrier to entry difficult, but it also allows entrenched players to stay there even when their technology probably needs an upgrade. And so while there's been a lot of safety groups that have recognized this, the FDA being Exhibit A, really, that there's issues with the current pumps, there's been a lot of limited data to actually use to look toward to drive innovation, and that's where our center comes in, and that's where our program of research is really, we're really trying to generate those data to say not just we have a problem, but these are the issues, these are the worst issues, these are the things that need to be fixed, and these are the design inputs that need to be included in every future pump. That's what we're trying to do here. And you say the dose error reduction system was a quantum leap in safety. Unfortunately, it gets bypassed a lot of times in the clinical setting. You say, how can that be? Why would end users, mostly nurses in this case, bypass these really cool safety features? Well, because like a lot of things, the user interface isn't always easy. The complexity of the device user interface is hugely high, and it varies from pump to pump. So there's no standard where the go button's always here, or even the language about running, stopping, starting. Is the words that they use are different. We've done a lot of comparison studies and published on this. It also takes a lot of time to program. There's lots of multiple steps to program the dose error reduction system. I'm an ICU nurse. When your patient's crashing in front of you, you don't have 30 seconds to push these buttons. So literally, you'll just put it into, you'll just manually figure it out. You'll just punch in a number 30 or whatever the number is that you calculated for the dose that and hopefully you're right. So it's bypassed for the right reasons, but sometimes results in, obviously, unexpected and unhappy outcomes. And also, because the technology is so old, you can't even put all the drugs, the drug library capacity is limited. So now a nurse might look for the drug and it's not even there, or the dose that they need. This is especially true in oncology infusion clinics, where so many things are so individualized that you can't really put everything in. So they don't often even have a choice of bypassing the library. And think about this, these are cancer patients, they need exactly what's ordered. So the current systems just don't support that practice, which is the whole point of our research. And so the majority of errors that we found that have been reported by us or others are incorrect programming of the dose error reduction system or complete bypassing and just programming in basic infusion. There's also other usability issues. They weren't really designed very well for bedside use, certainly not in an ICU where you might have patients on 4, 5, 6, or 10 channels of pumps. That's a lot of space. So they're large and heavy. These pumps are too big. They're not designed for transport. Most of the IV poles don't support it. They're not heavy enough on the bottom, so they literally tip over and crash. In fact, my mom had an MI a few years ago, and I was in the hospital with her, and I heard this loud crash a couple doors down, and literally the pole had just tipped over with, I don't know, X number of pumps on it, which I did take a picture of, which is kind of funny. Nurses bypass it's not user-friendly, which is why they bypass the safeguards. The screen size and viewing angles are terrible, so that's really bad in the day. It's even worse sometimes at night. Secondary medication administration, which we focused a lot of our work on. We have to drop, all the nurses in the room, we have to drop the primary bag to get the secondary to flow, is just completely manual process. That's crazy in this day and age with these, we have all this cool apps on our smartphones, yet to deliver life-saving medications, you have to do all this manual jerry-rigging every single time. And there's too many non-actionable alerts and prompts. I know Steve mentioned alarms. They beep constantly, and 90% of the time, those beeps don't result in anything you need to do except hit the silence button. So clearly, the beep shouldn't be there in the first place. And then when you have multiple lines, there's really no good way to deal with that. The manufacturer setups are really unrealistic for these linear peristaltic pumps, again, where you have to drop the primary bag in order to get the secondary to flow. And the other thing is it's not even achievable for the parameters that if you actually dig through and find the some of the setup requirements on page, 332 in the Baxter manual. When you have constraints of limited space at the bedside, you're also competing with other systems like that. That's a Philips monitor hanging in the corner. If you can't put an IV pole under there, there's not enough space. If you've got a ventilator, you've got ECMO machine, you've got all tons of equipment. Even if you knew exactly what to do and you were 100% committed to do it, we found through our observational studies that most of the time it's not even possible. So there's too much manual and too much unrealistic things. And then talk about recalls. FDA recalls medical products if they've been deemed unsafe, and there's 3 classes of recalls related to, and class 1 is the highest risk. If you have a class 1 recall, it basically means, it says, according to the definition, that you have an imminent risk of harm or death because of a particular piece of functionality on this equipment. That's kind of a big deal, wouldn't you think, if you're in the hospital? So here we have these IV smart pumps, and we dug through the recall database from 2015 to 2022, and all of our research is really driven by its clinical relevance. Every time we try to make a trade-off in our research, you know, in a way we set up a test or even a topic that we choose to pursue, we always ask ourselves, what's the clinical relevance? That always drives how we approach the problem. So in this case, we mostly study the BD Alaris pump, the Baxter Sigma pump, and the ICU medical pump, and there's a very simple reason, because up until now, and probably still true, those were the most 3 prevalent pumps in the market. Therefore, that's going to have the greatest clinical relevance. And the Baxter Sigma and the BD alone, up until recently, comprised about 80% of the market. So if we just did those 2, we'd really hit most of the issues. So that's why we looked at those 3 pumps in the recall database. And so there's a graph for each one, but if you look at the box on the left, the total recalls, BD Alaris has had 18 class 1 recalls in the last 7 years, and 14 of them have been in the last 2. That's kind of scary. Baxter's had 4, and ICU Medical's had 1. So there's clearly a lot of area for improvement here. So it's a major initiative of our center to do IV smart pump research. And you can see that's Dr. Jimenez and Janine in the lab. Up in that upper picture, but we want to create evidence-based standards, and we want to generate IP. And as I mentioned earlier today, here's our list of technical collaborators, which we really lean on tremendously. So our goal is really what's the whole point? Well, it's to decrease the incidence of medication administration error during IV smart pump use. And we want to address the usability safety issues. So these are some of the major things that we're looking at. So we've studied and disseminated a large number of usability issues in both the lab and clinical settings in our publications. And you can find those online because they're almost all open access. We've looked at the impact of those manual setup requirements and what it does to flow rate and what it does to medication administration errors. We've looked at medication administration error overall, so not just due to flow rate and setup, but also due to programming errors. And then Janine has started an entire program of research, guided by Juan, who's been very helpful in our lab setup, so thank you, on flow rate accuracy and occult med error. So anybody who's done any clinical, any you nurses or nursing students have probably gone into the room or seen the nurse you're working with go into the room a half an hour, 45 minutes after the med was hung, and it should have been gone in 30 minutes, and there's still half the dose there. And then you sort of look and say, why? And well, why is because this is a occult med error. Because of some aspect of the setup has resulted in a decreased medication flow, so therefore that medication doesn't get delivered on time. If you're lucky, you find it. If you're not lucky, you don't find it until the next dose is due maybe 8 hours later, and now you've had a missed dose. So you can't make that up. So these are the things that we really want to address. And here's just a couple of pictures of us in our lab with our undergraduate students who helped us with a lot of flow rate studies this summer. And I am now going to pass it on to Juuso. Thank you. You have to either put this here or hold it, or you can stay there, whatever you want.
All right. That's good. Now, thanks everybody for joining. Let me just take this out. All right, thanks everybody for joining and hanging on with us this afternoon and talking about this really, really fascinating topic of infusion technology. I've had the chance to work on infusion pumps for quite some time at ECRI and seen quite a lot of issues, as well as encouraging to also see a lot of solutions to some of these technologies, or some of these challenges that infusion pumps and infusion technology face overall. So in case you're not familiar, I was going to talk a little bit about ECRI as an organization that I represent. ECRI is an independent, not-for-profit medical technology research organization. We've been around for over 50 years in helping hospitals select medical devices that best suit their organization's needs, as well as trying to push healthcare technologies to deliver safer and better products through our research efforts. Our mission is advancing effective evidence-based healthcare globally. And we do this through various different efforts, from providing pricing transparency to healthcare delivery organizations, regarding capital equipment and consumables, doing clinical evidence assessments and looking at the state of clinical literature when it comes to therapies, drugs, and devices. And also, we are one of the countries, if not the largest, patient safety organization. So we analyze a lot of patient safety incidents, events, near misses, and trying to drive for insights from those to try to help healthcare organizations prevent harm from occurring. And specifically the part of ECRI that I represent is the independent testing laboratory that we have just outside of Plymouth Meeting, Pennsylvania. I'll talk a little bit more about those efforts regarding infusion pumps in just a second. ECRI is a global organization. We are headquartered in Plymouth Meeting, Pennsylvania, which is just outside of Philly. We have offices around the globe, as well as most recently our International Research Center that was opened up in Malaysia to look into globally available medical devices that are not yet cleared in the US. Most importantly, one of the biggest developments in ECRI's recent history was we joined forces with Institute for Safe Medication Practices, another major nonprofit working in the patient safety arena, specifically focused on medical device, medical safety through various different guidelines, as well as consulting work around this to try to really help medication safety efforts across various different fronts. And as a combination, we now encompass a lot of engineers, scientists, clinicians, infection preventionists, pharmacists of various different disciplines, and trying to really bring that collaborative insight into all the projects that ECRI conducts. And specifically, ECRI is one of the dominant aspects, and really the organization grew in the late 60s, early 70s around the medical device evaluation program. So that's a program that you can think about it like Consumer Reports, but for medical technology. We test and evaluate medical devices ranging from sutures to MRI machines to infusion pumps, and try to push them to their limits and provide unbiased feedback to the healthcare community to help hospitals select the products that best meet their needs, as well as push those technologies to deliver better safety solutions over time. And specifically when it comes to smart pumps have been a focus area for our team since the 70s. So my colleagues and our team have seen the various generations of the development, from just a device that is pumping accurately to devices that offer safety technologies, dose reduction systems, and even interoperability nowadays. But when we evaluate infusion pumps, this is an effort where we invite all manufacturers who offer a technology in that particular category. We invite them to offer their products for testing in our laboratories against a standardized set of testing methodologies and expectation. I've had the chance to work with Karen over a number of years and gotten a lot of great feedback in regards to some of our testing methodologies in this regard. When we test infusion pumps, we focus on a number of areas to really try to highlight what are some of the core differences that exist in the technology today. And it's important because, again, infusion pumps, like how Karen mentioned, they're used literally everywhere. You have hundreds or even thousands of these devices in your organization, and they often can represent a multi-million-dollar purchase. It's not just a pump, it's the pump. It's the consumables. It's the associated drug library editor software. It's the maintenance software that clinical engineering uses to ensure that those devices are functioning appropriately. It could be integration interfaces to your EHR to ensure that you're getting your benefits of EHR interoperability with your infusion pump. So there's lots of different components there to think about, and lots to cover when it comes to infusion technology. So when ECRI evaluates really any technology, we focus on a couple core themes: performance, safety, workflow and ease of use, cybersecurity, interoperability, and maintenance, to try to really deliver on a comprehensive view on how do these technologies stand up against one another, because differences do exist, regardless of the technology category you focus on, but also when it comes to infusion pumps. When it comes to performance, we focus a lot on pushing infusion pumps to their operational limits, and are certainly interested in looking at doing even more in terms of various different scenarios of infusion accuracy testing, et cetera. Because again, I think Karen alluded to this a little bit earlier. Again, when you're looking at an infusion pump, you're expecting the performance to be approximately plus or minus 5% of what you programmed. So when you program it for 100, it's not really 100. It's kind of around 100. And most of the time, the testing that has been conducted is in idealized settings for the device, but it may not take into account all the various clinical use cases that can introduce additional error. And I think that's where it becomes a challenge of when the error becomes clinically significant and you need to address it in one way or the other. So there's definitely technology differences there as well. When it comes to safety, we review a lot of the safety technology, dose error reduction systems available for all of the infusion pump vendors. The good thing is it's available from everybody, but the thing is that there are differences across what's available. There's maybe some limits that some infusion pump vendors do slightly differently, and there's certainly usability challenges when it comes to even just the generation of the set drug library and distributing it out to all of your infusion pumps. But beyond just looking at software and notification, our team looks at reasonable misuse scenarios. And one of the interesting examples that still persists today with some infusion pumps is you can take the tubing set and you can load it incorrectly. And that incorrect loading can impact the delivery, and the pump will not know. The pump is not aware of what is infused through it in most instances. The infusion delivery is oftentimes it relies on expectations of movement of, for example, the peristaltic fingers that move the fluid forward. So misuse scenarios and looking for those is definitely one core point of what we do. Ease of use and workflow. We do usability testing as part of all of our product evaluations, specifically with infusion pumps, extremely important. As Karen mentioned, there's various different designs, various different input methodologies. Some have arrow keys, others have numerical keypads, others have touch screens, others use color, others are black and white screens, and they are effectively, they're still used for the same purpose, but the user's experience of using that is completely different. Beyond usability, we definitely have worked with a lot of healthcare facilities in regards to selection of products and selection of the best infusion pump to meet their needs, and often find that those organizations that take into account the frontline clinician perspective have had a lot of success, because again, when you select an infusion pump today, you're looking at having it for the next 7 to 10 years in your organization, just because, again, the magnitude of that decision and all the associated components that go with it. ECRI also looks at interoperability, which is definitely a hot topic when it comes to infusion pumps. So just a simplification, interoperability is kind of like tying your infusion pump electronically to your patient's medical record and leveraging that electronic connection to deliver on patient safety benefits as well as workflow efficiencies. So interoperability, I feel like from most of the healthcare facilities that we deal with, it is on everybody's roadmap, but again, it's certainly a nice to have technology, but there's a lot of realistic challenges in implementing that. Again, while there are hundreds of hospitals who are doing it currently in the US, it's certainly not just I buy the feature and that's it. It's almost the next level of infusion safety and management that is required to ensure that that system is kept up to date. Beyond interoperability, that definitely implies that most infusion pumps that are used today are wireless. With wireless comes cybersecurity risks, which we're also including as part of our evaluation or review, focusing on identifying any cybersecurity concerns that may be present with that particular type of device. And last but not least, maintenance. Again, maintenance is really important with infusion devices. Most of the time, you're looking at touching an infusion pump once a year to verify its performance, and that can be a significant effort for many organizations. Again, if you have thousands of these in your organization, it's not just testing it, it's finding it, taking it out of service, using whatever testing software you have to figure out if the pump is still delivering within what it's expected to, and then putting it back into service. Replicating that process for multiple thousands of times results in a lot of resources required to it. So overall, ECRI utilizes the insights that we've gained through some of these hands-on evaluations to, number one, drive for incident investigations and identify potential areas of improvement, which in some cases have led to global recalls. Number two, we also look at general insights about health technology hazards. Again, one of our highest profile publications that's freely available for, is our top 10 health technology hazards. And infusion pumps, unfortunately, are a frequent flyer on that list. That list focuses on identifying key priorities for healthcare delivery organizations to address during the upcoming year. So if you're looking for some challenges to solve, there might be some good ideas in some of the ECRI top 10 health technology hazard lists. And lastly, I wanted to mention, since the partnership with ECRI and ISMP, Institute for Safe Medication Practices, there's been a recent update in 2020 in regards to the smart pump guidelines from ISMP. It's an absolutely crucial document if you want to optimize the management and safe use of your smart pump. So I would definitely encourage you to take a look at that one as well. Well, with that one, I want to pass it on to you. Thanks so much.
All right, good afternoon, everyone. Okay, so my name is Juan Jimenez. I'm a faculty member here at the College of Engineering. And my talk today is going to focus on IV smart pumps and essentially looking at the technology behind the medication flow. So essentially these machines that provide perfusion to the patients. And so background on the smart pumps, and some has been very nicely provided by the previous speakers, but one of the highest risk of interventions in the US, acute care, is the delivery of IV medication. And 90% of hospitalized patients will receive an IV infusion during their stay. And IV smart pumps have been widely adopted for delivery of IV medications, and they're great because you can program them and you can set the flow rate at which the infusion can occur, and it's wonderful. It's very nicely if you can control it properly. Unfortunately, IV smart pumps are among the most frequent source of device-related error reported to the FDA, as we've heard from our previous speakers. And in terms of looking at the systems that are out there in the market, the predominant ones, there are two main ones. Is the linear peristaltic systems, which are the ones on the top, and on the bottom are the cassette-based systems. My talk today is going to focus on the linear peristaltic systems, the BDLRs and the Baxter Sigma pumps. And so when you think about flow rate accuracy, one of the most important variables is like, you go as a clinician, you program in the flow rate, and then the number that you see on that screen that is displayed, you're hoping that that's going to equal the infusion rate to the patient, right? That's what you hope. But when you program that flow rate and it does not equal the infusion rate, what the patient's actually receiving, then now you have a medication dosing error. So these errors are very difficult to detect at the bedside. you go, you look, you're a clinician, you come back to a pump, well, it shows 100 mLs per hour. You went away, and you come back an hour later, and there's still 50 mLs in that 100 milliliter bag. So it's very difficult to detect what the problem is. And so one of the challenges with IV smart pumps is that they lack a feedback sensor to correct the flow rate and or inform the operator. So you go in, you set the number, you allow it to start running, but there's no feedback sensor. So you as a clinician, you come back and the pump does not provide you information and, hey, it's moving, the flow rate is lower or higher. And that's a main challenge of these pumps. And then lastly, setup actually plays a very big role in the flow rate accuracy when you're using these linear peristaltic pumps. And I'll show you what I mean by that. So this is what happens when you invite the engineer to the nursing topics. Equations have to show up. So here, the equation I have here, it's I started with the conservation of energy and make some simplifications and ended up with the following equation, where we have velocity at 0.4. So if you look at my cartoon, you have a 0.1. Let me see. You have, okay, so we have here 0.1 is where the IV bag is, and that is at the level, top level of the fluid. Here you have the IV smart pump. 0.2 is at the inlet of the pump. 0.3 is at the outlet. And then 0.4 is going to be at the point in the patient where the infusion is occurring. So it could be in an arm, it could be closer to the heart, but at that specific point. All right. So then the equation that we're looking at, we have velocity at 0.4, so that's the velocity at that point. And velocity, flow rate, and velocity are proportional to each other. And we have the square root of 4 times, in open parentheses, pressure at 0.1. So what do I mean by pressure at 0.1? So whenever you take the IV bag, you load it up with the medication, whatever the atmospheric pressure was that day is going to be the pressure if you have air at the top of that bag. And in general, atmospheric pressure does not change that much from day to day, but it'll change a little bit. Okay. P4, that's going to be the pressure at the arm or closer to the heart, wherever the end of that line is inside the patient. So it'll be close to somewhere about 10 millimeters of mercury, somewhere around there, give and take. The next variable is going to be the density of the liquid inside the IV bag, if it's saline or some other medication, but it would probably be close to water. G is going to be the gravitational acceleration, and then H is going to be the vertical distance between the top level here of the fluid and the center of that pump. And the way I drew this cartoon, I aligned the center of the pump with the heart of our patient. But so if that pump was a little bit higher or lower, we will have to take other variables into account. But for this example, we're just to simplify it. And then HL, this is actually very important. This is the head loss. So head loss, what does mean is the amount of energy that you're losing due to the tubing. And that could be because your tubing has a lot of turns, or maybe has a kink in it, or maybe has additional connections. So during the times when COVID, at the beginning of the pandemic, where you had the IV smart pumps outside of the patient rooms, and now you had multiple lines to be able to connect it all the way outside of the room, that affects that variable, the head loss, okay? And then the last one is the pump head. So that is the pumping capacity of the pump. So for clinicians in general, with some limit, these two, H and HL, those are the variables that you have control over. Some control. The others, you have pretty much no control over those variables. So let's focus on those two specific variables. So here we're focusing on H and HL. So H is going to be that vertical distance. So and from the center of the pump to the top level of the fluid. And then the head loss is whatever is happening to that tubing. So someone steps on it, there's a kink, there's many turns, those are going to affect that flow rate. So let's see what happens when H decreases. So that means that that IV bag, instead of being at this height, now is lower, closer to the pump. When you lower that height, now that means that V4 is decreasing. So the velocity or the flow rate, the infusion flow rate, it will be decreasing. So And then for HL, when it increases, it's going to have a similar effect. So that means that the flow rate is also going to drop. So the more turns you have, more kinks you have, the more connections you have, your flow rate is going to decrease. The challenge is, when you look at the pump, hey, it shows 100 mLs per hour, right? It should be 100 mLs per hour. Well, not exactly, because the way these have been designed, it is dependent on these other variables. So how would you know that? Well, let's say that you're a clinician, and you actually made it all the way through the manual for the pump, and you made it to page 308. So actually, you're really good. You made it all the way there. And you suddenly find this warning that says flow rate inaccuracy. And you read the first sentence, and it states, rate accuracy can be affected by variations in head height, back pressure, and back pressure will be affected by that head loss term that I was showing you, or any combination thereof. And then it goes ahead and provides a bunch of examples. Okay? So if you made it all the way through that manual, you'll find this warning. So how does that, when I'm talking about the variables that you have control over as a clinician, I make it sound somewhat simple, right? But in reality, when you look at a critically ill patient, reality is very different. This is a picture from the in a room with a critically ill patient. Look at a number of IV smart pumps in that room. And even if you knew that the setup for one pump is 20 inches or using another brand and it's 24, where are you going to be able to set up those pumps? There's no way. So, this is a challenge that goes back to, how can we address that? So I want to show you some preliminary measurements that we've done. We're working on these just to give you an idea what happens when you change the head height. So I'm showing you here measurements for 3 different flow rates: 25 mLs per hour, 100 mLs per hour, and 999 mLs per hour. Okay? And this is for the Baxter pump and the Alaris pump. The dashed line here, where it corresponds to 0, it would mean that the number that you enter is the actual flow rate going into the patient. So if your pump you enter 100 mLs per hour, and essentially one of those spots align with that line, it means that you're getting the flow rate that you actually enter. So what we can see here, let's focus first on the Baxter pump. We can see that, and then these numbers down here correspond to the height with relation to the center of the pump. So if you go higher, it'll be a positive number, and if you go lower, it's the negative numbers. And then the last piece of information, because before I talk about the data, are these green rectangles. And that corresponds to the height defined by the manufacturer. So as you can see, for the Baxter pump, the top level, the IV bag, has to be 24 inches high. But if suddenly you move to another hospital and now they use Alaris pumps in the hospital, now you gotta know, wait, I gotta use a 20-inch head height. Okay? So keeping that in mind, you can see that for different flow rates, and in general, these are preliminary data, but in general, you can observe that the difference between the program flow rate and the infused flow rate, actually, it's quite different. And for the Alaris, we see very large deviations. And with the Baxter pump, we specifically see that it's actually a function of the flow rate. It gets worse as you increase the flow rate. So in conclusion, setup errors using linear perspective pumps can lead to serious dosing errors. And again, the problem is you get no feedback from the pump. There's no feedback sensor. And secondly, the technology that is used in the clinical environment must be designed so that the products and devices are safe for the patient care. And it makes it easier for the clinicians to be able to work with the devices. Lastly, I want to acknowledge the members of my lab, especially Donald and Janine, that are the folks that actually did the work. I just get to talk about it. And then the funding agencies and entities, and Karen, that has been a wonderful collaborator to work with. Thank you for your time.
Thank you so much. Is this on still? Oh, good. Hi, everyone. As everyone knows, I'm Cidalia Vital. I was a 2020 graduate of the UMass College of Nursing, which is now the Elaine Marieb College of Nursing. And I'm so excited to be here because I just took on a new role at Baystate Medical Center as a nurse scientist. And I've had the honor and the pleasure of being introduced to Giuliano, Dr. Karen Giuliano. And she has a deep passion for IV smart pumps. And I have to tell you that I feel that same passion. So I'm just going to reflect a minute on sort of my role as a staff nurse over the years, and some of my colleagues are in the audience, which is wonderful. Do you guys remember the Dialaflow? And that was that little device, yes? You want to talk to the audience about what it is?
It was a device on the line that you could manipulate to control the flow.
Right, the drip rate of the IV. So when IV smart pumps first came out, I remember we still had the Dialaflow. And staff was like, no way, I'm not using that. I don't trust that pump. I'm going to go back to the old method. And here we are, how many years later, talking about, are these pumps accurate? And it's amazing to hear because I have been talking to nurses for the last, since 2003, and they've said to me, I don't know if I trust these pumps. So a perfect example is I worked in a pre-op setting for many years, and we did a lot of preoperative antibiotic administration. So prophylactically, we'd want to give antibiotics to prevent surgical site infections. And the staff nurse would say to me, Cidalia, are we really giving the 50 cc's of antibiotic to this patient before they go on the OR? Is there something missing here? Are we getting that entire 50 cc's into that patient? And are we really preventing surgical site infections? That's the perfect question. And now I'm in this role, and I get to talk to the staff and ask them, what's bothering you? So when Karen came to me and I said, do you want to partner on some research? I said, absolutely, let's do it. So I'm just going to talk a little bit about our partnership, and I'm going to say one other thing that's kind of funny. It came to my mind while everybody was talking. Who used the B-Braun PCA pumps? Anybody in this room? The code for that pump, and I still remember it, is 94369. That's how you would unlock it. That was the most important thing that I remembered of those pumps, instead of the fact that I was going in and giving a patient an epidural PCA, or I was giving a morphine or dilated PCA. So I want to think back to how simple we need to think about IV pumps. And we're in the place now where we're trying to prove that these pumps are not effective. So I'm so happy again to be here, and we need to rebuild that trust of the staff. So I'm going to move my slides. I didn't do that. I apologize. So we already talked about what the reality is, and being that I was in an OR setting, I spent a lot of time with instructions for use. So anytime a patient went at the OR table, we had a different piece of equipment, we were reading the instructions for use in the OR. But in the bedside, in a med-surg ICU setting, that was not happening. You were just there to take care of that patient, make sure we kept them alive. And so when we were talking a little bit about height differential, and Dr. Jimenez was talking about all of the algorithms that honestly, I was like, oh my God, this is exciting, but I'm so confused, but I will talk to you later more about that. The only one thing that I know we do really well in the ICU setting, and Sue Scott, you can tell me, it's the A-line. We want to match it up to the phlebostatic axis so we're able to measure an accurate blood pressure. That is the only time I've ever taken out a ruler or a measurement to do any sort of thing. So when you're sitting in an ICU and you're trying to take care of a patient, there's no way we can do that. So what we're doing is we're actually going to be working in the ICU at Baystate Medical Center and doing 2 studies, because we know that the ICU patients are the highest risk patients. They account for 78% of all med errors. And the issue of flow rate inaccuracy, which Dr. Jimenez spoke so eloquently about, is when the actual medication flow rate does not match the flow rate displayed on the IV smart pumps. And I can tell you, I don't think any nurse realizes this is happening. And so next year, Joanne and I were talking, we need to get more staff nurses here, because they need to hear this, because then they're going to be asking more questions, which would be great. So Baystate has what's called a Learning Health Systems Grant, and I don't want to bore you guys with this, but it is an amazing opportunity for us to do some quality improvement and research projects at our hospital. And when I met Dr. Giuliano, Karen, we immediately submitted a grant. So we were awarded a $30,000 grant to measure with pharmacy, nursing, and the College of Nursing and Engineering, actual versus programmed IV smart pump flow rates on 50 critically ill patients. And we're going to do some education in between because, like I said, I don't think a lot of staff nurses realize that they're not doing it correctly and that the pumps aren't being measured correctly, so the flow rate's accurate. So we're going to look at measurements using both the manual counting calculations and an external flow rate meter, which can be attached to the IV line. So we'll be doing that hopefully soon. We just got that awarded. So the main outcome is to develop an evidence-based staff education program to improve IV medication administration and safety at BMC, which we know is really important. And then the second grant that we received, we're going to be a Baxter site, and it's a similar thing. We're going to have a convenience sample of 100 ICU patients with 3 or more active infusions, which at Baystate Medical Center, I can tell you is not an issue. We have plenty of ICU patients to go around, so we'll be able to get those 100 patients pretty quickly. So we're partnering with Orlando Regional. They're the BD Alaire site, and Parkview Medical Center, which is the ICU medical site. And the observations of the IV smart pump setup with multiple infusions, including number and type of IV lines, venous access device use, multi-line infusion connections, and fluid medication type and rate. And this data will just add to the body of knowledge that you're already doing, Karen. And Dr. Supp, I am so happy to be here, and I am with you on the future of this is going to change the world, and I really appreciate the time today. Thank you.
Thank you, everybody. That was really good.
I took a few notes throughout the day here, so I just wanted to do a summary. It'll be just another hour. No. So first of all, thank you all for attending today. Karen and I are really excited to host this, and really I think we kicked off something that was really exciting. And I think maybe to summarize this, I'm going to read an email response. I think you might remember this email response. We got over the summer. We sent out our Save the Date response, and we got some nice responses back about information. We also got one response that said, nursing and engineering, question mark, question mark, question mark. 2 unrelated subjects. People in engineering are not interested in nursing and vice versa. I think our conversations today have realized that nursing and engineering are much closer than we realize, and there's a lot of complementary work to be done. And I think the nurse engineer really revolves around the patient's problems, and that really brings us together using sort of the quantitative and qualitative methods that we both bring to the table. And really, I think it's starting a lot from observation, right? I think, our panels had said it. It's seeing what the nurses are seeing on a day-to-day basis. It's what engineers are seeing, being able to get into the hospitals, get into the clinics, and working with people. I think it's really, really important. And I think the mission of our center is also sort of being defined. I think it's a prototype itself, right? We're one of the first in the nation. We've put forward an idea of what we think a nurse engineering center is, but getting feedback from you all and from our panelists and all of our collaborators, I think is going to help us refine it and continue to make it better and, in the coming years, really grow it into something that's really going to have a lot of impact in the fields. So with that, thank you all for coming today. We look forward to seeing you again in the future.